Yeah, or maybe a little kind of sessile papule that's sticking out maybe from the side of somebody's hand or something along those lines. And you said there are these fascicles of nerve running in this thing. Are they normal nerve fascicles? Well, good. We'll look closely now. So do these look like normal nerve twigs? If I took a biopsy of you and we looked at it, would your nerves look like this?
It's kind of haphazard, so I'll say no.
What about the number?
Kind of increased.
Yeah, a lot increased. Okay. You know, and there might even be a little bit of sort of fibroplasia here surrounding these areas, and they're little nerves that some are round, some are smaller, some are kind of irregular in shape. Doesn't look atypical, but they don't look like normal nerve twigs, do they? There's too many, there's fibrosis. So what's the diagnosis here?
I call this an accessory digit.
Okay, good. Now, it is an accessory digit. That's correct. But if we cut off your finger and looked at it under the microscope, what would we see?
Bone.
Bone, cartilage, some nerves, some blood vessels. Wouldn't be fun, would it? So why is this accessory digit got all these nerves here? What's really going on with an accessory digit? Well, sometimes if you actually biopsy an accessory digit, you'll actually see the cartilage and the bone and all that kind of stuff. But usually what happens is these things, the theory is they get auto-amputated in utero, and so what's left is usually a little tiny nubbin that's a traumatic neuroma. So this histology is of a traumatic neuroma. This is too many nerves with fibroplasia with a little sparse inflammation, and the nerves vary in size and shape. So this is basically a traumatic neuroma. But it's at the site of where there, once upon a time, probably was a full-fledged little accessory digit. Now, what are a couple of other neuromas that you have to sort of put in the differential diagnosis, and we'll just move on to this one pretty quickly, but what's another neuroma that's induced by trauma? One other one.
PEN.
Well, that's not really a traumatic neuroma. That's kind of a neoplasm. You get little fascicles of nerve twigs and some clefting, and it looks like it's encapsulated, but it's not. But there's one other type of neuroma that's induced by trauma that you need to know about. Anybody know? Come on, I know somebody knows. What happens if you wear high-heeled shoes for years on your Morton's neuroma? Okay, so this neuroma, which is a traumatic neuroma, happened because it got cut off like a guillotine. Okay, chopped off its head, and it's Wallerian generation, and it's trying to form these nerves, or trying to reform the nerve that once upon a time was there that was normal. So this is an attempt to neurotize, if you will, this guy's accessory digit. Morton's neuroma doesn't give you this kind of change. It gives you just a lot of scar tissue, and the nerves kind of are gradually choked to death. So it's a slow strangulation of the nerves to get a lot more fibrosis with some irregular nerve fascicles embedded in a thick sort of scar-like morphology. So it's a little different morphology than this. So that's a traumatic neuroma digital. So switch over to PowerPoint. Okay. So here you go. See, that doesn't really look like an actual digit now, does it? It's probably just a little kind of twig. So what was thought to happen here is that these things are like basically traumatized or auto-amputated inside the womb, and then they come out and they look like this. So this is basically a traumatic neuroma, but it's an accessory digit is the right answer. So you're correct. Okay, let's keep going. All right. Who wants to do this one? Some of them are great examples, and some of them are sort of a little lesser examples, so it's good to get cases that aren't always obvious. Different situation here, right? We're not dealing with a neoplasm, are we? So who wants to go?
Okay, so I see a punch biopsy. It looks like there's two different sections. One's cut horizontally and one's cut vertically.
So what does that tell you we're looking for?
Probably looking for an alopecia.
Absolutely.
There's a little bit of minimal inflammation, but we do have retention of the sebaceous glands. I think it's probably most likely non-scarring. at this
Good.
point. This section, I didn't see a whole lot going on. I got a little bit more from the other vertical section. And this one, I do seem to see a little bit of variation in the hair shafts. They seem to be a little bit of varying diameter. Again, a little bit of minimal inflammation. I was kind of leaning a little bit more towards an androgenetic alopecia.
There's definitely some background features of androgenetic alopecia. There's no question about that. I totally agree. So that's, if you said that, that's fine. However, there's a couple of other things here, and this isn't, again, the world's best example of it, but you see this fracture in the internal root sheath right there? A little cuticle around the hair shaft and the internal root sheath area. That may be a histologic artifact, but it may not be. And if you read the literature, that's something that you can see in this condition. Another thing that sometimes is helpful, if you see empty follicles with no hair shaft in them at all, that's kind of a clue. And then if you look over here,
That's, yeah, one with a little bit of a remaining hair follicle, like almost like what you'd see in like trichotillomania.
yeah, what's that called when you get a sort of degenerated hair shaft in the follicle? Trichomalacia. What's malacia mean? Good guess. I think it actually means kind of softening. Now, so yeah, this is trichotillomania. She probably does have some background androgenetic alopecia. And maybe, you know, what happens in some cases, a lot of people that have trichotillomania, and it's probably a bad name, you know, because they're not all maniacs that have the disease, but maybe she starts losing her hair, she's got androgenetic alopecia, oh my gosh, my hair's falling out, and then they start pulling, twisting, and whatever to sort of test to see if their hair's falling out, and then they get secondary trichotillomania. So this isn't a florid case like some we see, but you can make the diagnosis, or certainly suspect the diagnosis when you see those other changes. But how many follicles should be in antigen in this biopsy normally at this vertical section like this? So how many of these rooted in the fat should we normally see?
Most of them.
Yeah, but what number is that roughly? On a nice, excellent biopsy like this, how many should you see down here?
6.
About, yeah, 8 to 10, usually if somebody's got a nice luxuriant head of hair, like most of you guys in this room. If you looked at mine, I'd probably have about 2. So, you know, this is androgenetic. It's definitely an alopecia here. So when you look at something like this and it looks like the face, you should definitely say, hey, that really looks like androgenetic. And she probably does have some background androgenetic. So this is androgenetic, probably plus trichotil. And we'll switch over to the PowerPoint and show you a picture of it. How do you switch to power? Okay, there it is. This is a nice example, and this is a different pattern than you see with alopecia areata. It's kind of a diffuse pattern. It also involves the crown, and you get hair shafts of different lengths. And this, again, can be seen in either boys or girls, usually in younger individuals, but it can be seen in adults also. You may see catagen follicles. It's different than alopecia areata, where you see sort of a synchronization of the follicular cycle. Here, you don't see that. You see hair follicles, different stages of involution. And then, of course, you'll see the trichomalacia and other changes that we saw. Now, what's the difference, real quick, between this and traction alopecia? So they both, you know, traction's a permanent alopecia also, and somebody said that there's scarring in that. There is. Well, what's the histology? They're both traumatic alopecia. One is twisting, and one is slow pulling. So just like we had Morton's neuroma and traumatic neuroma, one's quick death, one's slow death. You get quick sort of degenerated follicles from twisting acutely, and then if you put your hair in cornrows for many years, you basically end up getting a slow death. What does that look like histologically? Nobody knows? Perifollicular fibrosis around the follicle, usually kind of the whole thing, not just at the infundibulum area. It's just gradually, when you pull on that hair slowly for years, you just start building up fibrous tissue around the follicle, and it just gradually chokes it off. Okay. All right. So we'll move a little bit faster on some of these others. Okay. Who wants to give this one a try?
We have a microphone for the next contestant.
I promise no one's going to bite if you take a crack at it. It's the best way to learn, by the way.
I can do this one. This one,
Good.
I think it was either a punch or an excision.
Or there's one other technique that's done. Like on the scalp, when you got those pilar cysts, what kind of technique is that?
You know, just like an incision and
Yeah, nucleation,
Yeah.
which favors benign or malignant.
benign.
Yeah, it pops out. Good.
Yeah, so I thought this was a benign neoplasm.
Excellent.
It's kind of differentiating toward like glandular morphology and has these just kind of what's the word?
Several layers of epithelium. It's not
Yeah.
just one layer. Good.
Like a maze almost. And then on one, this does right here looks like it has apocrine.
Yes, beautiful example of apocrine or decapitation secretion.
And then there was one cut, I think it was the edge cut, it looked like it was connecting to the surface. There were maybe a few plasma cells scattered through here, so I thought this was an SPAP,
Okay.
but I wasn't.
Now, what looks almost exactly like a syringocystadenoma papilliferum but is not thought to always connect to the epidermis, it can focally.
An HPAP,
Yeah, and what's, for the people in Brazil and India, is an HPAP?
Hidradenoma papilliferum.
Yeah, Hidradenoma papilliferum. Is it Hidradenoma or Hidradenoma?
I guess Hidradenoma, since that's what you said.
Is there a difference between hid and hide?
The tense of the word.
No! It's spelled differently. You know, one is HID, which has to do with sweat, and one is HYD, which does not have to do with sweat. It has more to do with, I think, water or something like that. The HYD is different. So, you know, hidradenoma, HYD, is a different thing than hidradenoma. So this is a hidradenoma papilliferum. And let's go to the PowerPoint.
So those can connect to this.
They can focally, yeah, like this. And usually if this were syringocystadenoma papilliferum, in addition just to connection to the epidermis, there's usually marked verrucous epithelial hyperplasia. So those things really look verrucous. So here's one. These are often seen in the genital area. Here's the labia you can see right there. It looks like a pyogenic granuloma almost. They can be beneath the epidermis completely, but they can sometimes have a little superficial connection to the epidermis here, but it doesn't have the verrucous epithelial hyperplasia that you see with a syringocystadenoma papilliferum. Now, where's the most common location for syringocystadenoma papilliferum? And what is it associated with?
Scalp
And association?
associated with.
Nevus sebaceous. Yeah, good. That's an easy one. What's the other name for syringocystadenoma papilliferum? That's one you probably don't know. Werther's nevus, W-E-R-T-H-E-R, apostrophe S. So that's one that's a fairly uncommon name, but it's one that's historically interesting. Okay, here's another one. Who wants to do this one? At low power, what do we see?
This is a shaved biopsy at low power. It does not look like there's too much going on.
Good. So your differential diagnosis of sort of the nothing stuff, right? So how do you approach a nothing slide?
You can start at the epidermis and kind of work your way down and see if there's anything abnormal that you may see.
And
What I
yeah, good,
ended up seeing was a little bit of pigment
good.
in the dermis, the superficial dermis.
Okay. What kind of pigment? And where was it located?
And more hemosiderin, I feel, that it looked like it had more of this sort of coppery color.
Okay, it was brown.
Brown.
Good. And you said hemosiderin.
Mm-hmm.
Are you positive that it's hemosiderin?
I'm pretty sure, but I could be wrong.
You could be wrong. Okay. Could be right. Let's take a look at this little focus right here. Does this look like hemosiderin deposition to you? What does hemosiderin usually look like?
Coppery color, and not as granular as melanin would look.
Well, actually, no, it's very granular, and it's refractile. It's kind of yellow-brown, and usually the individual globules are kind of relatively, they're probably about maybe this size right here, possibly. But what's this going on here? What are these? They look like fibers, don't they?
They do look like fibers.
What kind of fibers?
Maybe elastic fibers.
Elastic fibers. Good. Why do we see them? Do we normally see elastic fibers staining brown on our routine H&E section?
No.
No, we do not. Does hemosiderin usually stain elastic fibers like this?
No.
What does? These little granules over here also.
What stain would? Or
Yeah, let's say you wanted to do an elastic tissue stain.
Verhoff and Gießen? Or
Yeah, that's an elastic tissue stain, all right. And why does it stain the elastic fibers? What's the actual chemical substance of the stain that gives this elastic fibers their color? Like this is hematoxylin stains DNA and RNA blue, and eosin stains the collagen pink. What's VVG staining the elastic fibers with? What's the active ingredient in the stain?
I'm not sure.
Okay, anybody know?
Is it iron?
No? Silver. So if this is silver and it's staining the elastic fibers, what's the diagnosis? Argyria. Good. Now, what do you think this patient looked like?
Little blue.
Total body blue? Or total body dark? Well, what if I told you this came in as rule out melanoma? Let's take the PowerPoint.
Coming.
Would that think of like systemic argyria if that was the case? And this is another example to show it here. It's beautiful here, even better than our case. Here's what it looked like. This is localized cutaneous argyria, a little localized tattoo. And what's the most common cause of this? Yes, piercing. And we see this fairly common today because lots of people get piercings and maybe they decide they want to take their piercing out and let it go away, and then they end up getting a little localized cutaneous argyria. So just remember this, and it looks sometimes like melanoma clinically. Silver earrings, acupuncture needles, these are all things that can lead to localized cutaneous argyria. And the silver is the stain, is the active ingredient in a VVG stain. So we talk about silver stains, Worth and Starry stains, Steiner stain, those all have silver in them and they do stain elastic fibers.
7:32.
Okay. How are we doing on time?
7:32.
All right, 7:32. Okay, this is a fantastic case here.
Don't forget the 3-second lag, and don't push hard on the stage.
Okay.
Okay.
All right. Who wants to do this?
Okay, I'll do it. I wasn't really sure.
Good. If you're not sure, you should be praying. Hallelujah, you're not sure. That's fantastic. You should be very happy that you're not sure. You're going to learn so much on this case.
Okay, so obviously a punch of an inflammatory, what I thought was more of an inflammatory process.
Good.
And it's ulcerated, something that, basically left the epidermis dead.
Yes, this is bad news, right? Okay. Now, why is it dead?
And so I saw some interstitial debris, which I thought was somewhat like neutrophils with
Good.
neutrophilic dust.
Excellent.
And then I saw some red blood cells, which appeared to be in vessels.
Yes.
And I thought, okay, is there any vasculopathy or vasculitic process?
Is there only red cells in the blood vessels?
No, there's also this eosinophilic debris, which makes me think maybe vessels were once there and now are gone.
Well, they're actually still there. They're just dead, you're right. But what's this stuff here? You do know the answer. So if this is immune complex kind of mediated material, what's the final stuff that gets deposited inside blood vessels and blood vessel walls?
Fibrin?
Yes. So this is fibrin. So there's lots of thrombosis with tons of fibrin, and there are some polys, and there is some breakdown of some neutrophils, but it seems like there's a lot more thrombosis than there is neutrophils, right?
So then it made me think of a few things that have both a vasculopathy as well as a vasculitis. And so things like Levamisole.
Yeah, see, you did know the answer, didn't you? You knew. You were just hiding it from us all along. You did know the answer. That's exactly what this is. This is the Levamisole-mediated thrombotic vasculopathy. That's this cocaine stuff that's been adulterated with that. And notice how deep these vessels are involved here in the subcutaneous fat. And the one thing about this is not a leukocytoclastic vasculitis like typical LCV, right? It does have ANCA positivity, and sometimes you'll see relatively fewer blood vessels thrombosed with lots of polys, so that can be seen in some cases. This is the pattern that I've seen the most common, where you get lots of thrombosis, more thrombotic vasculopathy than inflammatory reaction. Sometimes you can get a lot of inflammation. So yeah, this is total necrosis here. This is collagen degeneration. What do you think this is going to look like clinically? See the PowerPoint.
Big hemorrhagic.
Yeah, purple, dead, eschar, bad news like this. And it gets you that stellate pattern, which means deeper blood vessels are involved, and this is all an infarct, and it's actually got some blisters that have developed here, so pretty nasty looking stuff. And the ears are commonly involved in this. So you all know what Levamisole is, you know this whole process, and they very commonly get these ANCA, both P and C ANCA in some cases. So this is a drug that was used to treat helminthic infections in kids, and they quit using because of the side effects, but now their good friends, the drug dealers, have decided to put it into cocaine. So good, excellent. Number 88. Okay, who wants to do this one? What do we see at low power? I thought I heard somebody say the right answer, nothing, just some normal skin. So we've already been through the differential diagnosis of normal skin once, right? Who wants to go through it in this one real quick?
I can do this one.
No, you don't get to go twice. Somebody else has to go. Those silent types at the end of the table down there? Liz, you hadn't been, have you?
No, sir.
You get to go. Isn't that fun?
Right, so we have a shave biopsy, which it looks like on April 6th. We went down our normal skin differential and started with Tinea.
Yeah.
High power balancing that looked like pigmented, so I said Tinea nigra.
Yeah. Why didn't you want to go? You got it right instantly. Good. So this is Tinea nigra. You can see the pigmented hyphae in the cornified layer here. What are the organisms that cause Tinea nigra? Anybody know? Alopecia boydii, Cladosporium wernickeii, which I think they've changed to Horti wernickeii. So just know a few of those. Why is the pigment dark?
No clue.
Anybody know? What is this? It's melanin. Just like you make melanin, fungus makes melanin sometimes. So melanin is what causes the pigmentation of the dematiaceous fungi, interestingly enough. So this, what do you think this came in as? Rule out blank. Melanoma, yeah. And why? Let's take a look at the PowerPoint. Look at this. So these often look kind of like melanoma. They're large, they're irregular, they are very symmetrical, they have irregular borders to them. So Horti is the new name for this. And we get an occasional one. You don't really even need a PAS stain here. You can see it usually with routine H&E. Okay. Now this one is so great. You guys should be fighting for doing this. Who knows what this is? Okay, somebody said it. Who hadn't gone? Let's work backwards. So what do we see? Punch biopsy, paniculitis, what's the pattern? Septal mostly, with a little bit of periseptal inflammation. And what kind of cells do you think we're going to see when we go to higher magnification? What kind of inflammation is present in erythema nodosum? Yeah, it's got granulomatous inflammation, especially late. Early you can see EOs, neutrophils. Later on you'll see histiocytes, multinucleated histiocytes. And you've got some of those here. Nice example. This is as good as it gets. So when they have something like this, it's so classic. They might just ask you, name several diseases associated with erythema nodosum. So what are a couple? Streptococcus, what's another one? Sarcoid? Yeah, tuberculosis, deep fungal infection, a bunch of different things can do it. So this is a beautiful example of erythema nodosum. Just doesn't get any better than this. Let's show the PowerPoint just so for completeness purposes. So here's the classic clinical features. Now, what form of erythema nodosum hangs on for years and is not associated necessarily with an internal disease? Who knows the name of that? Villanova's disease, chronic erythema nodosum. Okay? So there's a form that can go on for a long time. Okay. We lost a couple. Who wants to do this? Some of these are so good, you can do it from the cheap seats over there. Who hadn't gone? Oh, that's the best thing. Then you have a beginner's clean mind. You haven't been biased by anything, so. Good. They're large, yeah, and they're epithelially good. Okay. Let's go to higher magnification and see if there really are histiocytes. How about now? Good. Excellent. Neoplastic. Yes. So it's epithelial, mitotic figures, necrotic. cells, apoptosis, and adenocarcinoma. Good. Do you think this is primary to the skin?
Well, I mean, I think it applies to
But it doesn't actually arise from the epidermis. There's no true contiguity, is there? Good. And let's look at this little area here. This might give us a clue. What about that? Yeah, it's a lymphatic, and there's neoplastic cells in these lymphatics here. So now what do you think? Yeah, metastatic carcinoma, and the most common one that we see, there are adenocarcinomas like this, or metastatic breast carcinoma. So you didn't even need to look at the slides, right? Just get it right cold. Walk right in, make a diagnosis, right? No problem. So this is metastatic breast carcinoma. We have the PowerPoint to kind of show.
Sorry. It's coming.
Okay. It looks more like this, usually on the person's chest, often occurring near the side of the scar. That thing on the scalp, that's any kind of met can do that, but less likely for breast to do that. They usually occur on the trunk area, most commonly, rarely on the scalp. There's a couple of different patterns of metastatic breast cancer. If you see here, the cords, tubules, and nodule aggregations with ductal differentiation, that's kind of the ductal type that we see. The Indian file that you read about, that's more lobular. Clusters and abundant pools of mucin, that's the mucinous type. And then if there's a lot of lymphatic involvement, the inflammatory type, like the carcinoma en cuirasse pattern. So this is ductal carcinoma. You don't really need to know that so much. But you just, if you recognize that it's metastatic adeno-CA, that's the most important thing. So that's good. Everybody kind of get this one right? Anybody that's on the line, if you could mute your phone, that would be really helpful because you get a lot of feedback here, unfortunately. All right, now we're shifting to the beginning, which are kind of, for some people, are going to be like extra cases because we started off with 81, so now we're going to go back to the beginning. We'll work through these. We've got about 15 more minutes. So who wants to give this one a go? These are 5 slides in 15 minutes, or 3 minutes each, so we don't have time to. Now, you guys should know this because we just did fibrosing and sclerosing last week, and if I did my job, you should all get this right. Good. Why? Plywood appearance, great. So this is a sclerotic fibroma. So you did learn something last week. So I did my job, at least in part. And this is pretty much pathognomonic for the pattern of sclerotic fibroma-like change. So you can see sclerotic fibroma-like change in other settings than sclerotic fibroma like we talked about, like in neurofibroma, dermatofibroma, sometimes even in leiomyoma. So you can see the pattern in those other lesions. It doesn't have to be sclerotic fibroma. And we already talked about last week, Cowden syndrome, P10 mutations, all those good things. So just make sure you remember those. Unfortunately, this slide's kind of cracked, but it's diagnostic. I think we have the PowerPoint to show real quick. Okay, so here's a low power of a different case, but it looks the same. This is what they kind of look like clinically. They're fairly non-specific and totally benign lesions, but the problem is when they develop in association with Cowden syndrome. Okay, good. So it's fairly straightforward. This talks about Cowden's. You can treat these with sirolimus. These are some other P10 syndromes. You guys know what P10 stands for, right? Tumor suppressor gene gets mutated. Cells proliferate. You get that also in these other syndromes too, so make sure you know the P10 hamartoma syndrome for the boards. And this one's a good case. Hopefully you all got this one. So we've got looks like a biopsy that's just got only fat in it. It's kind of funny, isn't it? Maybe all the epidermis sort of went away and the dermis overlying it. Maybe they took a big punch and they had fat and put it in 2 pieces and only the fat part was included. So what do we see here? I think everybody's gone, so if somebody wants to go twice, they can now. Yeah.
It's not in vessels. I didn't think it was. So usually we're seeing a bunch of calcium in case like calciphylaxis. So I started thinking of other things that could express calcium in the blood.
It's always fun when an attending does that, right? You know, the patient gives you a history, and has they ever had any disease before? No, nothing, and the attending works, oh yeah, I forgot to say I had a brain tumor when I was 5 years old or whatever, so there is calcium, and it is in these small vessels too. Now you're right, it's not only in the vessels. Some of it's like between the individual vessels and the subcutaneous fat here as well. So does calciphylaxis have to be localized to the blood vessels? Yeah, it doesn't have to. It can occur, it can actually participate in the dermis also, but it gets in the blood vessels, and it also is associated with vascular thrombosis, but it doesn't have to be localized there. So, given that, do you want to modify your diagnosis? Yeah, good. It's calciphylaxis. What are a couple of conditions where you can get vascular or get calcification where it's not calciphylaxis? Yeah, pancreatic paniculitis, that's a different kind of calcification. It's saponification, which is basically you get abnormality of the fat and you form soap in the skin, so you get calcium stearate that gets formed, and that looks different than this. You get that kind of wispy, mummified fat with sort of a, looks almost like honeycomb calcification. And then, what are a couple other diseases? Not so much calcification in that. They get kind of those little crystals in the, they get hypercalcemia, but they don't get calcification of the skin usually. But there's a couple other diseases where you get calcification, calcinosis cutis. What was that again? Osteoma cutis, that can be calcified, but it really forms bone. Dermatomyositis, especially juvenile dermatomyositis. What other connective tissue disease? How about crest? The first letter means calcification, right? So crest, you can get it. Subabdominal calcified nodule. There's a number of diseases where you can get cutaneous calcification. We won't go through all of them today. Pyelometricoma, calcifying epithelioma of Malherbe. You get calcification in desmoplastic trichoepithelioma, little small islands of calcium form there too. So just beware of all the things that give you, we'll look at the PowerPoint now, calcification in the skin. Okay. So this is a low power of a different case. And then here you can see the calcium. We don't need that. I guess we didn't hide these. But mainly, this is the other thing that happens. You get epidermal necrosis. And this looks very much like the Levamisole case. I remember the first case I saw of this when I was a resident. I took a biopsy. I didn't even have to put in anesthesia. He couldn't feel anything. We did a punch biopsy right through one of these things. He was totally anesthetic because he'd basically killed his skin and he had nerves that were dead. And here's calcification and X-ray showing it here. And so anyway, this is mortality. We used to think it was 85%. There's a couple of cases that have the chronic calciphylaxis patients that actually do better. Interestingly enough, when we first used to see this a long time ago, almost everybody died, but now there are some patients that kind of go on longer, had renal transplants, and they still get calciphylaxis, but they don't all die from it. Okay, we got 4 more, right? No, 3 more. How much time we got?
8 minutes.
8 minutes, okay. This is a very nice example of this entity. Who wants to do it real quick? Good.
Seems like it's neoplastic.
Yeah. So it's vascular.
Vascular. I'm not sure the cell type, but then forming vessel looks like a hospital.
Yeah, so it's a vascular neoplasm. Does it seem to be benign or malignant to you?
Looks benign.
Yeah, it's dome-shaped, papular, good.
And there's eosinophils on the lymphocytes, so it makes me think it's
Yeah, angiolymphoid hyperplasia with eosinophilia. Now, we always talk about the hobnail endothelial cells, which is good and important to do. What else do you notice about these blood vessels in addition to the fact that these prominent endothelial cells here? They're pretty thick-walled, aren't they? And that's very characteristic of this disease. So not only do you get these hobnail endothelial cells, you also get very thick-walled blood vessels. And this has a lot of eosinophils in it, okay? So it's a nice example. It almost looks like a pseudolymphoma, just with prominent blood vessels. What does this look like clinically? What color are they? Yeah, they're kind of red. Let's take a look at the PowerPoint. Okay. See there? Brownish, reddish. Good. And that's a good location, the scalp, the ear area. What's one other disease that histologically looks very, very similar to this? Yeah, Kimura's disease. That's seen in what kind of patients? Yeah, Asian men usually. They get the same histology, but they get widespread lesions not localized to the scalp. And the histology looks pretty similar. Not exactly the same, but similar. So anyway, that's angiolymphoid hyperplasia of the eosinophilia. Okay. All right, this one was a little bit unusual, but sometimes it's good to see kind of variations on a theme. It's a punch biopsy. What's the main pattern here? Yeah, it's not totally deep. Yeah, kind of superficial and mid, perivascular, but also what else? Interstitial. Yeah, so perivascular and interstitial, and it does have some mucin in here. So what do you think about with that pattern, that diagnosis? Interstitial with mucin and some histiocytes. What, somebody said something? Yeah, Granuloma annulare. Now, what's unusual about this case of interstitial, mostly GA? EOs. Pretty unusual to get that many eosinophils in GA. It can happen. There have been some cases of GA that have been thought to be precipitated by bug bites. I don't know if that's what happened here. So this is definitely a little bit on the unusual side, but it's in the spectrum. And here you get some histiocytes between collagen bundles, and I don't know what that is actually. That may just be kind of an artifact, scratching or something like that.
Really big on one of the tests, and that was the first thing that went down like a subdermal.
Yeah, this is a little bit of an unusual case. Let me show you one that's a little different, that's not as unusual. So that would be probably one that they wouldn't give you on the board exam because it's a weird case, but it just shows you that apparently sometimes you can get EOs in interstitial GA. I guess that kind of fit best clinically in that case. I don't remember the exact time the diagnosis was made. This is one that's got some palisading, but it's got a lot of histiocytes between them on collagen bundles diffusely. So this is a better pattern. So if you were going to get one on the board, this is probably closer to what they would show you. Okay. Everybody got that right? Name two diseases that are a differential diagnosis of this. What was that again? Metastatic breast can give you an interstitial mostly pattern, good, or any kind of good, that can definitely do it. Sclerotic edema definitely can do it. Okay, that's two. We could get you a couple more, but we'll stop there. Oh, yeah, see the PowerPoint real quick. Yeah, why not? We did the PowerPoint, so let's look at it. Yeah, so this is not what interstitial GA looks like. It usually looks like macular pink areas, usually in the groin area, the trunk, usually of middle-aged women. It usually comes in as morphea or mycosis fungoides. Clinicians usually don't think about it. Sometimes interstitial GA in that setting can actually be perineoplastic, so you have to be aware of that as well, okay? And it can simulate metastatic breast, patch stage Kaposi's, sometimes Spitz's-Nevi, so there are a lot of different things that can give you an interstitial mostly pattern. Okay, the last one, we're doing good on time?
2 minutes.
2 minutes to go. Oh, good. All right. We'll show them this one and then we'll show the new. But this you can make the diagnosis on. So who wants to give this one a go real quick? Yeah, it's vascular once again, right? And it's round and well circumscribed. And we saw the case of Levamisole earlier that had fibrin. What's going on here? Yeah, there's fibrin here. This was a clot, and you've got all these new blood vessels that have got this villous papillary frond-like morphology associated with it. And over here, it almost looks like granulation tissue, like a pyogenic granuloma. So what's going on here? What's the diagnosis? Yeah, good. This is a so-called intravascular papillary, there's the papillary part, endothelial hyperplasia, or a Masson's tumor. And what's the pathophysiology of a Masson's tumor? Yeah, it's trauma. They basically get an injury, blood vessel gets thrombosed, this is reorganizing, it's kind of organizing thrombus, and then you do a biopsy of it because maybe it didn't go away and somebody's worried about maybe a neoplasm or something, and it turns out that it's basically just organizing thrombus, basically, is is going on here. So let's take a look at the PowerPoint. Finished on time. This is kind of what one of these might look like because they're dark, because they're clot, and blood when it gets dark gets black also. So again, this is basically just a traumatic lesion that gives clotting of the blood vessel inside, and then you get this sort of pyogenic granuloma-like recanalizing thrombus within the vascular space. So totally benign process, nothing to worry about. Do what? Hey, hi guys. Good job. Everybody have a good time? You're welcome.